Our mission is to move beyond just, naming parts. We want to understand the functional
The
architecture.
why of it all.
Exactly. The subtle choreography between blood vessels, nerves, muscle fibers, and specialized cells that allow these organs to function under constant mechanical and chemical stress.
So we're essentially reverse engineering the stomach. We're not just naming the parts. We're figuring out why they are shaped and connected the way they are.
Exactly. This is a deep dissection. We have 9 major sections to cover, and we will elaborate on every single one. We're starting with the minute, surprisingly short 2 to 3 centimeter abdominal esophagus.
Which is amazing in itself.
It is. Then we'll detail the complex mechanics of the lower sphincter, meticulously map the stomach's vascular network, which is a masterclass in redundancy, and then move into the oncological roadmap of its lymph drainage.
Finish up where?
We finish with the dual system of neural control and the incredible microscopic histology. This dive is fundamentally about appreciating the engineering resilience that's just built right into our digestive system.
Okay, let's start with what feels like the most overlooked segment, the abdominal esophagus. When we picture the esophagus, we think of that long tube in the chest.
Right, the thoracic part.
So how brief is this terminal segment, really?
It is shockingly brief. We're often talking only 2 to 3 centimeters long.
That's it.
That's it. But that short length, well, it makes it disproportionately critical. This segment is the final run. It extends from the cardioesophageal orifice, which sits roughly at the T11 vertebral level,
Good.
down to the actual entry point, the cardia of the stomach. And functionally, this short segment is the only portion that receives external compression from the abdomen.
Which is essential for preventing reflux, right?
Absolutely essential. It's a huge part of the anti-reflux mechanism.
And it doesn't just drop straight down. The source material mentions a defined path, a positional obliquity. What does that mean for its placement relative to other major structures?
The obliquity is key. It doesn't just plummet. It descends from the left, tracing a slight diagonal path as it enters the stomach.
And what's it next to?
Critically, this segment sits immediately anterior to one of the body's most significant blood vessels, the descending thoracic aorta. Knowing this precise anterior relationship is, it's paramount for any surgeon operating near the gastroesophageal junction. A careless dissection or, placement of clamps risks a major vascular catastrophe.
So it's in a very high-stakes neighborhood.
Extremely.
And we have to mention its passage through the diaphragm, the great muscle of respiration. Where does the esophagus actually pierce this muscle, and how does that relationship become functional later on?
So the esophagus passes through what's called the esophageal hiatus of the diaphragm. This usually happens at the T10 vertebral level, so a little higher than where it joins the stomach.
And this isn't just a passive hole.
Not at all. This relationship is foundational for the lower esophageal sphincter's function. Because the diaphragm is a primary muscle of respiration, its rhythmic movement and contraction provide constant external mechanical reinforcement to the sphincter.
Like a natural clamp.
It's a perfect analogy. It contributes significantly to that high-pressure barrier we need to maintain against stomach acid.
Okay, let's move to its coverage, the peritoneum and the fascia. Unlike the thoracic esophagus, this abdominal segment is in the peritoneal cavity, but we need to specify which surfaces are covered and why that matters.
That distinction is vital, especially surgically. So the abdominal esophagus is largely invested by peritoneum on its anterior and its lateral surfaces.
And what does invested mean here? Just covered?
Yes, wrapped or covered. And this investment means that these surfaces are relatively mobile within the peritoneal cavity. This mobility is a huge advantage in surgery.
How so?
It allows a surgeon to gently reflect or move the esophagus to gain better access to adjacent structures or, to perform a repair without having to fight against fixed tissue.
But the posterior side is different. You said it's an exception to the rule.
It is the anchor point. The posterior wall is unique because it's only loosely covered by peritoneum. This means the structure remains substantially fixed, pinned against the posterior abdominal wall.
What's holding it there?
The fixation is primarily due to the dense connective tissue surrounding a vital structure running down its back, the posterior vagal trunk. That inherent fixation dictates how a surgeon must approach the posterior aspect. You can't just move it around.
That makes sense. And that brings us to the ultimate anchor, the phrenoesophageal ligament. This sounds like an incredibly robust piece of biological engineering.
It truly is the critical mechanical anchor, and its composition is remarkable. It's made of dense connective tissue interwoven with a high concentration of elastic fibers.
So it's strong, but also stretchy.
Exactly. That gives it both strength and the necessary springiness. Its function is crucial. It limits the upward and downward mobility of the esophagus and its lower sphincter.
And why is limiting that vertical mobility so important, especially during something like breathing or coughing?
Well, during intense respiratory movements or coughing or straining, the pressure differential between the thoracic and abdominal cavities changes dramatically.
Right, you're pushing down hard.
You are. And the elastic nature of the phrenoesophageal ligament ensures that the junction and the sphincter remain largely anchored in their correct subdiaphragmatic position. The sources even note that the mechanism by which this ligament stabilizes the junction has been understood since the year 1290.
Wow, that's incredible.
It just underscores its fundamental role in human anatomy and health. It's not a new discovery, it's a core principle.
And structurally, how does it attach to achieve this stability? What's it connected to?
It has a dual attachment pattern, which is very clever. Superiorly, the ligament attaches and blends seamlessly with the transversalis fascia, which is the internal lining of the abdominal wall.
Okay.
And then inferiorly, it anchors the gastroesophageal junction firmly. This precise, continuous attachment ensures that the junction is held below the diaphragm.
So what happens if that anchor fails?
That's the key pathological question. If the elastic fibers stretch or the connective tissue weakens, which often happens with age or chronic strain, that anchor fails.
The whole thing slides up.
The junction can slide upward, leading directly to a hiatal hernia, which compromises the sphincter function entirely.
That brings us to the surgical implications, specifically the posterior relations and that high-stakes neighborhood of the vagal trunks. You mentioned we have two vagal trunks running down here.
We do. We have the anterior vagal trunk, which is mostly composed of left vagus nerve fibers, and it usually lies loosely attached anteriorly.
So that one's a bit easier to work with.
Generally, yes. A surgeon usually has more freedom working with this segment. The real surgical difficulty lies posteriorly, with the posterior vagal trunk, which primarily carries fibers from the right vagus nerve.
Why is the posterior one considered so much more dangerous and difficult to deal with during procedures like a vagotomy?
Well, it is deep, it's highly fixed in place, and it's often encased in dense, unyielding connective tissue.
And its position?
Its anatomical position is critical.
Mm-hmm.
It runs very close to the posterior wall near the pericardium, the sac that encases the heart.
So you're operating right next to the heart?
Essentially. Identifying and isolating this trunk during a surgical division, or vagotomy, which used to be done to reduce acid secretion, requires extreme precision. Misidentification or accidental trauma to surrounding tissues. It risks unintended cardiac issues due to that proximity.
And you can't just pull it into view.
The fixation is so substantial that a surgeon cannot simply pull the nerve into view. They have to meticulously dissect through all the surrounding fascia.
So a surgeon has to proceed with utmost caution posteriorly. But anatomically, you said there is a silver lining that helps improve the field of view, especially for procedures focusing on the junction itself.
Yes, the peritoneal reflection is our surgical friend here. The layer of peritoneum posterior to the abdominal esophagus is configured in such a way that it allows surgeons to perform a key maneuver.
What's that?
Reflecting the stomach and the peritoneum anteriorly.
So you can kind of peel it forward.
Exactly. This reflection is crucial because it significantly widens the working space. It provides vastly improved surgical access and visualization of the entire gastroesophageal junction, an essential step for procedures like a hiatal hernia repair or specialized oncological surgery.
Okay, we've crossed the threshold and are now at the gastroesophageal junction, the official meeting point. Let's start with the physical location of the cardiac orifice. Where is that exactly?
The cardiac orifice is the narrow entrance to the stomach. Anatomically, it's usually situated slightly to the left of the midline.
Okay.
And this corresponds vertically to the level of the 7th costal cartilage. And posteriorly, we're talking about the T11 or T12 vertebral level.
But the most visible and clinically dramatic transition happens internally. It's something called the Z-line.
Yes. The Z-line, or the serrated line, this is where the biological mandate of the two organs violently shifts.
Describe that internal transition for us. What does it look like?
It is a remarkably sharp and clear demarcation. You can see it very clearly during an endoscopy. The pale pink color of the esophagus, which is lined by stratified squamous epithelium.
The tough stuff.
Exactly, designed primarily for protection and wear resistance. That abruptly meets the reddish-brown columnar epithelium of the stomach.
Which is designed for secretion.
Intense secretion and initial absorption, this serrated, often jagged line is the Z-line.
And why is that line so important beyond being a nice visual landmark for endoscopists?
Because it is the point of greatest vulnerability. This junction is the site where cellular transformation or metaplasia most often arises.
Okay, so that's where the cells can change.
Right. When the lower esophagus is chronically exposed to stomach acid, the protective squamous cells are often replaced by intestinal-type columnar cells. That condition is known as Barrett's esophagus.
And Barrett's is a major risk factor.
It is the primary and most significant risk factor for subsequent adenocarcinoma of the esophagus and the cardia. So monitoring this precise line is absolutely central to early cancer screening.
Let's move to the lower esophageal sphincter, the LES. You stressed earlier that this is a functional sphincter. What does that mean in practical terms?
It means you cannot dissect it out as a single, perfectly defined anatomical muscle ring. It's not like the thick, visible pyloric sphincter further down.
There's more of a system than a single part.
It's a dynamic, integrated barrier system, not a single static clamp. The LES function relies on the synergistic cooperation of multiple anatomical structures and physiological pressures.
And the goal of this integrated system is to maintain a robust pressure barrier. What are the metrics we're looking at here?
The system has to maintain a high resting pressure gradient. We're typically talking a range from 20 to 50 centimeters of water.
That sounds like a lot.
It is. And this pressure is necessary to resist the powerful retrograde forces exerted by the acid and contents being churned up in the stomach. If the pressure drops below, say, 10 or 15 centimeter H2O, the risk of symptomatic reflux increases dramatically.
And this pressure barrier is built on 4 specific contributing factors. Let's elaborate on those mechanics. Factor 1, the baseline tone.
That's the intrinsic strength. The inherent resting tone of the smooth muscle fibers in the distal 2 to 3 centimeters of the esophagus provides the baseline pressure. These are tonically contracted muscle fibers.
So they're always a little bit squeezed.
They're always maintaining some tension, even at rest, though it's regulated by neural input.
Okay. Factor 2 involves the external environment. And this ties back to the diaphragmatic passage we discussed earlier.
Precisely. Factor 2 is the external positive intra-abdominal pressure. Because that short segment of the abdominal esophagus is situated below the diaphragm, it's continuously subjected to the higher pressure of the abdominal cavity.
So it's again squeezed from the outside.
It's physically compressed from the outside, and this external compression is powerfully reinforced by the sustained tonic contraction of the surrounding respiratory diaphragm itself, acting like an external clamp or a pressure cup.
And then we get into the ingenious muscle arrangement of the stomach. The unique architecture that turns a simple tube into a dynamic valve.
Factor 3 is perhaps the most anatomically fascinating. We're talking about the oblique sling fibers of the stomach.
Sling fibers?
Yes. These muscle fibers don't run longitudinally or circularly. They loop obliquely around the esophagus at the junction.
So they're at an angle.
Exactly. Imagine these fibers like a cinching belt or a noose around the esophagus. They provide a dynamic, asymmetrical clamping action that gives the stomach unique leverage that a simple ring sphincter could never achieve.
So when the stomach contracts, those fibers tighten the opening.
They effectively tighten the orifice. And this is combined with the modest thickening of the inner circular layer of muscle within the esophageal wall itself.
Finally, factor 4, the physical barrier created by the inner lining itself.
This is the physical block, the mucosal rosette or flap valve. The inner lining of the stomach at the cardia forms these complex mucosal folds. So when the stomach is full or contracts, these folds project into the lumen. If there's any upward pressure from the stomach, these folds are forced together, sealing tightly to physically block reflux, much like a check valve in plumbing. It provides the final, crucial mechanical layer of protection.
That synergy explains why the system is so robust. But let's look at what happens when cancer strikes this vulnerable junction. We talked about T1A and T1B staging, which defines the depth of invasion.
Yes, and understanding T1A versus T1B is paramount in modern oncological treatment. T1A adenocarcinoma means the lesion is confined strictly to the mucosa layer.
The innermost lining.
Right. And the importance here is that the mucosa lacks lymphatic vessels. Therefore, for T1A lesions, the risk of lymph node metastasis is very low, often less than 2–3%.
And if the risk is that low, the surgical approach could be much less invasive.
Correct. For T1A, the standard treatment is often endoscopic mucosal resection, or EMR. The surgeon uses an endoscope to carefully remove the lesion and a small amount of surrounding mucosa.
And so it's a local procedure.
It's safe, organ-sparing, and highly effective because the cancer hasn't reached the vascular highway, so to speak.
But the moment the cancer breaches the basement membrane and invades the submucosa, that's T1B, the entire prognosis and surgical requirement shifts dramatically. Why is that?
Because the submucosa is where the major lymphatic channels and larger blood vessels reside. It's the highway for metastasis.
I see.
Once the cancer invades the submucosa, or T1B, the risk of lymph node metastasis rises significantly. We're talking 10 to 40%, depending on the depth of that submucosal invasion.
So EMR is no longer an option.
It's no longer sufficient. At this stage, the patient requires a radical procedure, a formal surgical resection, which could be an esophagectomy or a gastrectomy, combined with a meticulous lymphadenectomy to clear all potential metastatic pathways.
We mentioned the phrenoesophageal ligament earlier as the critical anchor. When that ligament weakens, we get the common pathology of the gastroesophageal junction, the hiatal hernia.
A hiatal hernia is essentially an anatomical failure. It results from chronic weakening or stretching of that critical phrenoesophageal ligament.
Okay.
This failure allows the abdominal esophagus and the cardia of the stomach to be displaced upward, migrating through the esophageal hiatus into the thoracic cavity. It is a very common occurrence, particularly in older populations.
And what is the functional consequence of that upward migration? Why is it a problem?
When the junction moves superiorly into the chest, it immediately loses the benefit of that positive external intra-abdominal pressure we just discussed.
It's no longer getting squeezed.
The LES is no longer reinforced by the diaphragm's compression, and that severely compromises its anti-reflex function. The result is chronic symptomatic gastroesophageal reflux disease, or GERD, often requiring repair.
We've officially crossed the threshold and are now inside the stomach. It's easy to think of it as just a simple holding tank, but its function goes far beyond that, and its position is incredibly dynamic.
Variability is its defining characteristic. The stomach is the widest, most highly distensible part of the entire alimentary tract.
How big can it get?
Its capacity is massive. It can range from 1,000 to 1,500 milliliters in an adult, but its position and shape change constantly depending on its fullness, the pressure from surrounding organs, and even just the individual's posture.
Let's expand on those core functions. Beyond just digestion, what are the 5 or 6 essential roles the stomach plays?
Okay, firstly, its primary role is a temporary reservoir. This allows us to ingest a large meal quickly and then process it slowly over time.
Right.
Secondly, mechanical breakdown through powerful muscular mixing and churning. Thirdly, chemical digestion, which is primarily initiating protein digestion via highly acidic pepsin.
And fourth?
Fourth, its role as a gatekeeper. It regulates the precise, controlled emptying of chyme into the small intestine. Fifth, it facilitates limited absorption, mostly water, certain fat-soluble drugs, and critically alcohol.
And the last one is secretion.
And finally, and most importantly, the secretion of key substances. Hydrochloric acid, or HCl, intrinsic factor, which is essential for vitamin B12 absorption later on, mucus for protection, and digestive enzymes like pepsinogen.
Let's break down the anatomical zoning of the stomach into its 4 standard parts, starting superiorly at the entrance.
We begin with the cardia. That's the small, narrow region immediately surrounding the cardiac orifice, the entryway we just discussed.
And above that.
Next is the fundus, which is the dome-shaped portion that extends superiorly above the level of the cardiac orifice. Because of its superior position, this is the area that typically traps swallowed air and fermentation gases.
So that's the gas bubble you see on an X-ray.
That's exactly what you're seeing. It's often gas-filled and clearly visible on imaging.
Below that is the expansive main chamber.
That's the body, the largest central region. It extends inferiorly from the fundus down towards the lower boundary, which is typically marked internally by a feature called the incisura angularis. This body is the main site for acid and enzyme secretion.
And finally, we get to the specialized business end, the pyloric part.
The pyloric part is the distal segment. This is the region responsible for grinding and gatekeeping. It's subdivided into 2 distinct zones.
What are they?
The wider proximal part is the pyloric antrum. This is where the really strong mixing contractions take place. This then narrows considerably into the pyloric canal, which is a short, muscular tube only about 1 to 2 centimeters long, leading right into the duodenum.
Moving to the curvatures, we have the short, lesser curvature and the long, greater curvature, and each is defined by crucial peritoneal attachments.
Right. The lesser curvature is the concave medial border. Its defining feature is a deep notch or groove, the incisura angularis, which historically marks the functional separation between the body and the pyloric region.
And it's an attachment site.
Yes, it's the essential attachment site for the lesser omentum, which is an apron-like peritoneal fold containing the hepatic arteries and the gastric arteries.
And the greater curvature, the sweeping lateral side, provides a much wider attachment.
The greater curvature is the long convex lateral border. This curvature serves as the attachment site for the greater omentum, the large, fatty, protective apron that hangs down over the intestines.
And other ligaments?
Yes, it also anchors the stomach via specialized peritoneal folds, the gastrophrenic ligament to the diaphragm, the gastrosplenic ligament to the spleen, and the gastrocolic ligament to the transverse colon. These tethering points are crucial for surgical navigation because they define the vascular pathways.
I think it's worth revisiting the dynamic nature of the stomach. How much can the shape and position truly fluctuate?
The fluctuation is massive. The anatomical terms often depict the stomach as a static J shape, but in reality, it's highly dynamic.
So an empty stomach looks very different from a full one.
Completely different. When empty, the stomach shrinks and that incisura angularis sits quite high. When maximally distended, the entire organ descends, the curvatures lengthen, and the incisura angularis moves inferiorly and anteriorly, sometimes even making contact with the anterior abdominal wall.
So you have to account for that in imaging and surgery.
Absolutely. This dynamic movement must be accounted for in both diagnostic imaging and surgical planning.
Let's focus on the pyloric orifice, the actual exit point into the duodenum.
The pylorus, the muscular exit, typically sits slightly to the right of the midline. It corresponds anatomically to the transpyloric plane, which is at the L1, L2 vertebral level, a key benchmark for upper abdominal landmarks.
And the exit itself is controlled by what?
By the pyloric sphincter. Now, this is a true anatomical sphincter. It's a substantial ring of highly thickened circular muscle, which makes it distinct from the functional LES we talked about earlier.
And it's strong.
It contracts powerfully to strictly regulate the flow of chyme.
And for surgeons, there's an important visual shortcut on the surface, helping them locate this crucial gatekeeper.
That's the prepyloric vein of Mayo. This vein runs visibly across the anterior surface of the pylorus.
And it's easy to see.
It serves as an incredibly useful, palpable, and visual surgical landmark. It's often described as the surgeon's X marks the spot, allowing for rapid and precise identification of the boundary between the stomach and the duodenum without relying solely on palpating the thickened muscle.
Finally, we need to map the stomach's relations. What structures lie adjacent to its surfaces? Let's start with the relatively simple anterior face.
The anterior surface of the stomach is largely in contact with the left lobe of the liver and the inferior surface of the diaphragm. When the stomach is full and pushed anteriorly, it can sometimes be palpated against the anterior abdominal wall below the ribs.
The posterior surface, the stomach bed, is geometrically far more complex, and it's hidden behind a specific anatomical space.
That's because the posterior surface forms the anterior boundary of the lesser sac, or the omental bursa.
So there's a space behind the stomach.
Right. And the organs that lie in direct relation to the posterior stomach wall forming this stomach bed are multiple and critical.
What are they?
Superiorly, the diaphragm. Laterally, the spleen. And medially, the left kidney and the left suprarenal gland.
And deep to that.
Deep within this bed, protected by the lesser sac, you find the splenic artery as it courses medially, the body and tail of the pancreas, and the transverse mesocolon with the transverse colon.
That's a crowded neighborhood.
It's very crowded. And these complex posterior relations mean that diseases of the stomach, like a posterior penetrating ulcer, can quickly involve the pancreas or the splenic vessels.
We move now to the vascular lifeline. This is where the biological engineering really showcases its resilience. The stomach's blood supply is highly redundant.
It is a masterwork of collateral circulation. The arterial supply to the stomach is almost entirely derived from the celiac trunk,
Which is a huge artery.
a massive initial branch of the abdominal aorta. And the engineering strategy here is not just to supply blood, but to guarantee survival through extensive interconnected anastomotic arches along both the lesser and greater curvatures.
So there are backup routes.
Many backup routes. This design provides remarkable resilience against ischemia.
Let's trace the lesser curvature arteries first, forming what you call the superior arch.
Okay, we begin with the left gastric artery, or LGA. This is often the smallest, but a highly significant branch arising directly from the celiac trunk.
And what's its path?
Its course is complex. It ascends superiorly and to the left towards the cardia. It gives off vital branches to the lower esophagus and cardia. These are the primary esophageal arteries in this region.
Then it turns.
It then turns sharply to descend along the lesser curvature, running within the lesser omentum, supplying the upper half of that curvature.
And the right gastric artery completes that arch. Where does it typically originate?
The right gastric artery, or RGA, usually originates from the proper hepatic artery, though it can sometimes arise directly from the common hepatic artery.
Then how does it get to the stomach?
It travels across the upper duodenum and then ascends, running within the layers of the lesser omentum, typically situated about 1 to 2 centimeters away from the actual lesser curvature. It descends to meet and anastomose extensively with the LGA, completing that superb superior vascular arch.
Okay, now moving to the greater curvature, we find the substantial gastromental arcade forming the inferior arch.
This is a major structure. It is composed of the left and right gastromental arteries.
Let's start with the left one.
The left gastromental artery, the LGOA, is the largest branch of the splenic artery. It runs inferiorly and anteriorly, first within the gastrosplenic ligament and then continuing into the layers of the greater omentum.
And what does it supply?
It supplies the upper 2/3 of the greater curvature. This vessel is surprisingly large, sometimes measuring up to 8 centimeters in length.
Why so big?
Well, it reflects its critical role not just for the stomach, but also for supplying the greater omentum itself.
And the right gastroomental artery comes up from the inferior boundary to meet it.
Correct. The right gastroomental artery, or RGOA, usually arises from the gastroduodenal artery, which is a branch of the common hepatic artery.
And its path.
The RGOA travels along the greater curvature, often running slightly posterior to the stomach, and ascends to meet the LGOA. The anastomosis, the connection between the RGOA and the LGOA, is robust, creating this formidable inferior vascular arch.
So we have two major interconnected arches surrounding the stomach. What does that mean for surgical risk and tissue survival?
It means profound resilience. The extensive anastomoses of these superior and inferior arches make the stomach remarkably resistant to ischemia, even in the face of major vascular trauma or necessary surgical ligation.
Can you give an example?
Sure. During a radical gastrectomy for cancer, a surgeon might have to ligate the left gastric artery, the right gastric artery, and parts of the gastroomental arteries.
That sounds like you're cutting off most of the blood supply.
It does. But because of the richness of the collateral supply, blood can often flow backward through one arch to supply the entire organ. The stomach tissue usually remains viable. This is a crucial adaptation given the organ's active, chemically exposed role.
We also need to map the blood supply to the fundus and the posterior body, which are accessed via the gastrosplenic ligament.
Right. The fundus and the upper greater curvature are supplied by the short gastric arteries, or SGAs.
How many of those are there?
Typically 5 to 7 small direct branches originating either directly from the splenic artery or from its terminal or polar branches as it nears the spleen.
And why are these short arteries often described as challenging for surgeons?
Their location. They're located within the gastrosplenic ligament, which makes their management delicate. They are numerous, small, and very closely associated with the hilum of the spleen.
So there's a risk of damaging the spleen.
A significant risk. To access and divide them, which is necessary in many upper gastric procedures, like a sleeve gastrectomy or a fundoplication, the spleen must often be gently retracted. Damage to the splenic capsule or vasculature during this process risks significant hemorrhage or, worst case, requiring a splenectomy. And we should also mention the rare but documented posterior gastric artery.
This one isn't always there.
It's not always present, but when it is, it's clinically relevant. It typically arises from the splenic artery or sometimes directly from the celiac trunk, and it runs posterior to the peritoneum, supplying areas of the posterior body and fundus. A surgeon has to be aware of its potential presence during procedures involving the lesser sac.
Before leaving the arteries, let's highlight a terrifying, albeit rare, vascular anomaly: Guillofoy lesions.
Guillofoy lesions are a critical, rare cause of sudden, massive gastrointestinal hemorrhage. It's a frightening condition.
What is it exactly?
It is defined as a persistent, abnormally large, and tortuous artery, often 3 to 6 millimeters in diameter, which is substantial for a submucosal vessel that runs just beneath the inner lining.
Where does this usually happen?
Typically near the gastroesophageal junction. And the key is that this artery is exposed without the protective cushioning of standard submucosal tissue.
So if the lining breaks down,
when the overlying mucosa erodes, this unusually large vessel bursts, causing profuse catastrophic bleeding that can rapidly lead to hemorrhagic shock.
And it must be hard to find.
Due to the intensity of the bleeding, pinpointing the exact location endoscopically can be extremely difficult. It demands immediate and aggressive intervention.
If the arteries map the input, the veins map the output. All the blood leaving the stomach needs to travel to one final destination before it gets back into the systemic circulation.
That destination is the liver, and it gets there via the portal system. All gastric venous blood drains eventually into the hepatic portal vein.
But it's not a direct route for all of it.
No, the routes taken to get there are complex, and they generally follow the arterial supply.
So how does the venous drainage geographically break down?
We can follow the two curvatures again. The veins along the lesser curvature, the right and left gastric veins, are the most direct route. They drain directly into the main trunk of the hepatic portal vein itself as it ascends toward the liver.
Okay, that's straightforward. What about the rest?
The greater curvature and fundus drainage is more complex. It links to the two major tributaries of the portal vein.
How does that work?
So the blood from the fundus and the upper greater curvature flows via the short gastric veins and the left gastro-omental vein into the splenic vein. The splenic vein then merges with the superior mesenteric vein, the SMV.
And the other side?
Conversely, the right gastro-omental vein drains inferiorly into the SMV. This confluence of the splenic vein and the SMV is what forms the main portal vein trunk.
This complex mapping becomes vitally important when the pressure in the portal system rises, a condition known as portal hypertension.
And what's fascinating here is how the anatomy provides alternative emergency drain routes.
A backup system.
A backup system born of necessity. Portal hypertension typically occurs when the pressure within the portal vein rises above 15 millimeters of mercury, often due to significant obstruction, most commonly liver cirrhosis.
So the blood can't get through the liver.
Exactly. When flow through the liver is blocked, the blood must reroute through collateral systems to reach the systemic circulation, bypassing the liver entirely.
And this rerouting manifests as varices, starting most commonly in the esophagus.
That's right. Esophageal varices are a direct consequence of this rerouting. The blood, unable to enter the liver, backs up through the left gastric vein, which is also called the coronary vein.
And that vein drains the esophagus.
It normally drains the lower esophagus. Due to the high pressure, it becomes abnormally dilated. Because the veins in the lower esophageal submucosa are thin-walled and fragile, they balloon out, forming these varices.
And they can rupture.
They are extremely prone to rupture and can cause severe, life-threatening hemorrhage.
Gastric varices, however, often have a slightly different and sometimes more localized cause.
That's true. While they can be part of generalized portal hypertension, gastric varices, especially those highly localized to the fundus, are frequently associated with a condition called splenic vein thrombosis.
Thrombosis meaning a blood clot.
A clot in the splenic vein. And because the splenic vein runs immediately posterior to the pancreas, chronic inflammation or swelling, say from pancreatitis, can cause localized compression and clotting of the splenic vein.
So what happens then?
When the splenic vein is blocked, blood draining from the fundus via those short gastric veins is backed up. This pressure bypasses the systemic portal system block and causes large, localized varices, specifically in the fundus of the stomach.
And the treatment would be different.
Very different. It requires a targeted treatment approach, sometimes involving removal of the spleen rather than just treating the underlying liver disease.
Let's pivot from blood flow to the lymphatic system. For cancer treatment, this network is arguably the most crucial roadmap a surgeon possesses.
This is truly the ontological roadmap. The lymphatic system originates as a rich, dense plexus within the mucosa, and especially the submucosa of the stomach wall.
And where does the fluid flow?
The general rule is that the lymphatics follow the course of the major arteries and veins outwards, gathering into sequential regional groups of lymph nodes situated around the curvatures and the main vascular pedicles.
When treating gastric cancer, surgery relies on a specific, standardized classification system for these nodes, which dictates the extent of the resection.
Precisely. We use the internationally recognized Japanese Gastric Cancer Association classifications. These define lymph node stations based on their proximity and the risk of metastasis.
And are categorized.
Yes, into N1 and N2 stations. The staging provided by pathological analysis of these nodes dictates the necessity of what we call a D1 versus a D2 lymphadenectomy.
Okay, let's define the N1 nodes, which represent the immediate proximal risk zone.
N1 nodes are the immediate perigastric nodes. They're the first line of defense.
Yeah.
A D1 lymphadenectomy targets these groups.
Then where are they?
They are clustered along the immediate course of the 4 key arteries we just mapped. the left gastric, the right gastric, the short gastric vessels in the gastrosplenic ligament, and the left and right gastro-omental vessels along the greater curvature.
And if cancer is only in those nodes?
If cancer is contained within these N1 nodes, the prognosis is often reasonable, provided meticulous removal is achieved.
And the N2 nodes represent the deeper, more remote territory, carrying a much higher prognostic risk.
The N2 nodes are the major regional nodes, and removing them requires a more radical D2 lymphadenectomy.
Where are these located?
These are nodes clustered around the central structures and origins of the major vessels. This includes the nodes surrounding the celiac trunk itself, the nodes along the splenic artery as it courses posterior to the pancreas, those surrounding the common hepatic artery, and the nodes near the hilum of the spleen.
So these are the distant drainage points.
They are, and involvement here signifies a much more advanced stage of disease.
So the decision to perform a D1 versus a D2 dissection is entirely based on connecting the histology, the T stage, like that T1b invasion into the submucosa we talked about, with the risk of metastatic spread to these specific anatomical zones.
That is the core surgical principle. If the tumor is superficial, T1A, only a local excision might be needed. But if the tumor breaches the submucosa, T1B, or invades the muscularis externa, the metastatic risk rises sharply,
Requiring the more extensive surgery.
often necessitating a radical D2 dissection to ensure clearance of those N2 nodes. Understanding this geographical clustering and risk profile is absolutely critical for the modern surgical oncologist.
Why is that?
Because inadequate lymphadenectomy is a common cause of recurrence. The lymphatic system is truly the key to staging and prognosis in gastric cancer.
We've seen the physical structure and the circulation, but how does this entire chemical plant get its moment-to-moment operating instructions? That brings us to the command center, innervation, which involves two major systems working in tandem.
Right. We have the stomach's own internal brain, the intrinsic control system, or the enteric nervous system, the ENS.
The second brain.
The second brain, exactly. This system includes the myenteric plexus, or Auerbach's plexus, which is situated between the muscle layers and coordinates motor function, or motility, and the submucosal plexus, or Meissner's plexus, which regulates local secretion and blood flow. This allows the stomach to manage local tasks like peristalsis or gland function relatively autonomously.
But the master input, the accelerator and the brake, comes from the autonomic nervous system, starting with the parasympathetic supply, the vagus nerve.
The vagus nerve acts as the primary accelerator, promoting intense activity. It descends into the abdomen as the anterior and posterior vagal trunks.
And the branching is specific.
It's highly specialized, almost like a dedicated power grid. The anterior vagal trunk, primarily carrying fibers from the original left vagus nerve, gives off critical hepatic branches that travel towards the liver, gallbladder, and biliary system.
And to the stomach.
Crucially, yes, it continues as the main anterior gastric nerve supplying the anterior stomach wall.
And the posterior trunk is more about signaling the rest of the GI tract.
Correct. The posterior vagal trunk, carrying fibers mostly from the right vagus nerve, is the major workhorse for distal signaling. It gives off powerful celiac branches that dive down to synapse in the celiac plexus.
And from there?
From there, it supplies the entire mid and hindgut, the intestines, pancreas, and spleen. It also gives off the main posterior gastric nerves to the stomach's back wall.
So what's the function of all this vagal input?
Functionally, vagal input is intensely stimulatory. It promotes motor function, or motility, and powerfully stimulates glandular secretion, driving the production of hydrochloric acid and pepsin.
Contrast that with the sympathetic supply, which generally provides the brake and the stress response.
The sympathetic input originates from the thoracolumbar segments of the spinal cord, typically T6 up through T10 or T12. The pathway is via the greater splenic nerve.
And where do these fibers go?
These fibers travel down without synapsing until they reach the celiac plexus. There they synapse, and then the postganglionic fibers follow the arteries to the stomach wall.
What is the resulting action when the sympathetic system takes command?
Sympathetic activation is the inhibitor and the diverter. It generally inhibits motility, slowing down the powerful churning action of the stomach.
And it affects blood flow.
Critically, it causes immediate vasoconstriction of the gastric blood vessels. This diverts blood flow away from the digestive process and towards the muscles or other vital organs during a stress response. It also decreases glandular secretion.
So it's the fight or flight switch.
It's the physiological switch that shuts down digestion when the body is in fight or flight mode.
Finally, let's discuss pain sensation. If something is going wrong in the stomach, like an ulcer or inflammation, where does the patient actually perceive the pain?
Pain sensation from the stomach is notoriously poorly localized, which is characteristic of visceral pain.
So you don't feel it right where the stomach is?
Not usually, no. The sensory pathways travel back along the sympathetic nerves to the spinal cord segments T6, T10. Consequently, the pain is typically referred to the epigastric region of the upper central abdomen.
The pit of the stomach.
Exactly. However, pain originating specifically from inflammation or severe irritation at the gastroesophageal junction like intense reflux can be referred higher.
Where to?
To the retrosternal area behind the breastbone and the subxiphoid area due to the shared sensory pathways with the lower chest region. This overlap often makes it difficult to distinguish gastric pain from cardiac or esophageal pain based on location alone.
We've mapped the macroscopic geography and the neurological wiring. Now we are diving deep into the microscopic level to see how the stomach actually builds itself and runs its internal factory floor. Let's start with the wall layers, moving from the outside in.
Okay, if we take a cross-section of the stomach wall, we start externally with the serosa. This is simply the visceral peritoneum, a thin outer layer of connective tissue covered by a simple squamous epithelium called the mesothelium.
And its job?
Its function is primarily protective. It ensures the stomach can glide smoothly against other internal organs during movement and contractions.
Below that lies the physical engine of the stomach, the muscularis externa. This layer is highly specialized because of its three distinct sublayers.
The three layers are the core of the stomach's ability to mix and churn food. Unlike the rest of the GI tract, which typically has only two layers, longitudinal and circular, the stomach adds a third.
So what are the three?
First, the outer longitudinal layer, which is most continuous and prominent along the two curvatures. Second, the thickest layer, the middle circular layer, which becomes dramatically thickened at the distal end to form that robust pyloric sphincter.
And the third, unique layer.
The third, and most unique, is the inner oblique layer.
What purpose does that unique inner oblique layer serve?
The inner oblique layer is primarily found in the fundus and the upper body. Because its fibers run diagonally when they contract, they provide a powerful twisting and grinding motion.
So it's not just squeezing, it's wringing.
It's a great analogy. This complex, three-dimensional contraction pattern ensures food is completely pulverized and mixed with the digestive juices, a much more efficient mechanical action than simple circular or longitudinal squeezing alone.
Next, the supporting structure, the submucosa.
The submucosa is loose connective tissue that forms the essential support structure. This is the vascular and neural highway we talked about. It contains the submucosal nerve plexus, critical lymphatics, and the larger blood vessels that supply the inner layer.
And it's the layer where cancer spreading becomes a major problem.
Exactly. This is also the layer that, when invaded by cancer T1b, signals the need for radical surgery due to the presence of those lymphatics.
Finally, we reach the innermost layer, the highly structured mucosa.
The mucosa is the thickest inner layer. When the stomach is empty, it's thrown into temporary visible folds called rugae, which flatten out completely when the stomach is distended. This layer contains the epithelial lining and the millions of microscopic gastric glands.
Which are the true functional units of secretion.
They are.
The epithelium itself lives in a highly corrosive environment. It must have an incredible defense mechanism.
Its defense mechanism is rapid replacement and a thick mucus barrier. The surface is lined by surface mucus cells that secrete a highly alkaline protective layer of thick mucus and bicarbonate.
But the real key is the turnover rate.
What is remarkable is the speed of cellular replacement. The surface mucus cells are replaced constantly, achieving a full turnover sometimes every 3 days.
Every 3 days.
Every 3 days. Even the mucus neck cells turn over roughly every week. This high turnover is essential for survival against the high acidity and mechanical abrasion.
Let's follow that lining down into the functional microfactories, the gastric pits and glands.
The surface epithelium dips down into shallow depressions called gastric pits. Multiple gastric glands, which are long tubular structures, open into the base of each pit and extend deep into the mucosa.
And these glands are the chemical microfactories.
They are, containing 4 distinct and essential cell types, each with highly specialized machinery.
We need to detail these 4 specialized cell types, starting with the parietal or oxyntic cells. These are the ALK producers.
The parietal cells are large, intensely eosinophilic, so they're pink staining cells, found primarily in the middle and upper parts of the glands in the body and fundus. They are responsible for 2 vital secretions.
What's the first one?
First, they secrete hydrochloric acid, HCl. They achieve this through specialized massive amounts of membrane called secretory canaliculi, which are invaginations lined with microvilli.
And these canaliculi are where the action is.
They house the high-powered proton pumps that actively move hydrogen ions into the lumen, generating a pH as low as 1.0.
And the second secretion?
Second, they secrete intrinsic factor, a protein that is absolutely necessary for vitamin B12 absorption later on in the ileum. Damage to these cells, as in pernicious anemia, prevents B12 absorption.
Next are the chief, or zymogenic cells.
The chief cells are typically located deep in the base of the glands. They are characterized by abundant rough endoplasmic reticulum, or RER, the cell's machinery for protein synthesis and packaging.
And that tells you what they do.
It reflects their primary function: the secretion of inactive digestive enzymes, specifically pepsinogens and lipases. These inactive pepsinogens require the highly acidic environment created by the parietal cells to cleave and activate into the protein-digesting enzyme, pepsin.
We mentioned the mucous neck cells. What is their specialized role, distinct from the surface cells?
The mucous neck cells are found closer to the top of the glands, interspersed among the other cells. While surface cells provide that thick protective barrier, the neck cells secrete a distinct, more soluble type of mucus.
And what's that for?
This mucus is crucial for lubrication and helping to protect the underlying cells from mechanical damage as food churns. It supplements the protection provided by the surface layer.
And finally, the smallest but most powerful players, the neuroendocrine cells.
These are the hormonal regulators. They are scattered throughout the mucosa, often abbreviated as ECL cells, for enterochromaffin-like cells.
And they're sending signals.
They produce a variety of local hormones like gastrin, which stimulates acid, histamine, which powerfully potentiates acid secretion, and somatostatin, which inhibits acid secretion. These hormones act locally in what we call paracrine signaling to modulate the activity of the parietal and chief cells.
So they're fine-tuning the whole process.
They're fine-tuning acid production and motility based on neural input and chemical feedback.
Before we transition to the actual movement of the stomach, we have to talk about the unsung heroes of motility, the interstitial cells of Cashal, or ICCs.
The ICCs are absolutely crucial. They are the electrical heart of the gastric system. They are specialized mesenchymal cells found primarily within the muscularis externa and submucosa.
And their job is to be the pacemaker.
Their primary role is as pacemaker cells. They spontaneously depolarize and generate slow-wave electrical contractions, essentially setting the fundamental rhythm that determines the frequency of peristalsis.
So they set the beat that the muscle fibers follow.
They set the rhythm, ensuring the stomach contracts predictably, typically at a rate of about 3 times per minute in humans. Without the ICCs, the muscle would contract randomly and inefficiently.
And they have clinical significance beyond that.
They do. Clinically, they are also recognized as the origin cells for most common gastrointestinal stromal tumors, or GIC, highlighting their profound structural and functional significance in the GI tract.
We know the anatomy, and we know the factory floor. Now let's see the system in action. Gastric motility. It's defined by 2 dramatically different functional zones within a single organ.
The stomach manages a complex dual function that's defined by its regions. The proximal region, which encompasses the fundus and the upper body, functions primarily as a highly compliant storage reservoir.
How does it manage to store a large volume of food without causing a massive, painful rise in internal pressure?
Through a sophisticated mechanism called receptive relaxation.
Receptive relaxation.
Upon swallowing, a process mediated primarily by the vagus nerve, the muscle in the proximal region actively relaxes. This relaxation allows the stomach to expand dramatically, accommodating a large volume of food while maintaining low intragastric pressure.
So it stretches out to make room.
It respects the volume ingested, making it comfortable to eat a large meal.
The distal region, the antrum pylorus, does the opposite. Its function is violent mechanical breakdown.
The distal region is the grinder. Its primary function is mechanical breakdown, mixing, and homogenization. This region exhibits powerful phasic contractions that start mildly and increase dramatically in amplitude as they sweep toward the pylorus.
And they're regular.
They occur steadily, at the rate set by those ICC pacemakers, about 3 times per minute.
The system has built-in feedback loops, ensuring it doesn't overwhelm the small intestine. It acts as a smart valve.
It acts as an incredibly smart valve. Motility and emptying are highly regulated by the inhibitory enterogastric reflexes.
What triggers those?
These reflexes are triggered immediately by specific chemical signals detected when the newly expelled chyme enters the duodenum. The most powerful inhibitory signals are triggered by the presence of fat, acid, or high concentrations of protein in the duodenal lumen.
So the duodenum is telling the stomach, slow down, I can't handle this much fat right now.
Exactly. Signals are sent back to the stomach via both neural and hormonal pathways to inhibit proximal muscle contraction and drastically slow down the rate of emptying. If the chyme is too acidic or too fatty, the reflex is activated until the duodenum can neutralize and process the material it has already received.
And the chemical mediators of this inhibition are key gut hormones.
Yes, we have several inhibitory gut hormones that act as the chemical brakes. Cholecystokinin, or CCK, released primarily in response to fat, is the most powerful inhibitor.
What else?
Secretin, released in response to acid, tells the stomach to slow down acid output. Also involved are glucagon and vasoactive intestinal polypeptide, or VIP. They all work synergistically to ensure the duodenum is not flooded.
The vagus nerve, which we said was the accelerator, still plays a vital role in coordinating this whole process.
The vagus nerve is essential for coordinating the proximal and distal regions. It mediates that proximal receptive relaxation upon swallowing while simultaneously stimulating the powerful distal contractions needed for grinding. It keeps the entire system synchronized.
Finally, let's detail the precise action of the pylorus, the ultimate gatekeeper, and how it handles liquids versus solids.
The contracted pylorus is the arbiter of particle size. When contracted, it still permits the rapid passage of liquids. Liquids can squeeze through the narrow opening relatively easily due to pressure gradients.
But solids are a different story.
However, when it comes to solid food, the regulation is absolute.
How does the stomach ensure that solids are properly ground before being passed on?
Only solid particles that have been reduced to a very small size, typically 1 to 2 millimeters, can pass into the duodenum. Large solid matter cannot pass through the contracted sphincter.
So what happens to it?
Instead, the intense force of the distal antral contraction propels the large solid food matter forcefully backward into the antrum.
It gets pushed back.
This violent mechanical process, called retropulsion, ensures that the food is repeatedly subjected to grinding and mixing, like stones being turned in a grinding mill, until the particles are small enough to be selectively expelled into the duodenum. It demonstrates the immense mechanical power and sorting intelligence of the distal stomach. #outro.
What an incredible journey through the upper GI tract. We truly dove into the functional architecture, from the 3 distinct muscle layers that enable grinding and mixing to the highly resilient vascular arches that ensure redundancy, the precise, complex branching pathways of the vagus nerve, and the intricate cellular factory floor staffed by 4 distinct cell types: parietal, chief, mucous neck, and neuroendocrine.
It's a lot to take in.
It is. The level of detail required for a surgical understanding, as contained in Chapter 63, really confirms the elegant engineering of this system.
And if we connect this detailed anatomy to the bigger picture, the entire system is a masterclass in dynamic, resilient control.
How so?
The strong anastomoses of the arterial arches mean the stomach is one of the safest organs against ischemia. The unique 3 layers of muscle ensure complete mixing and powerful mechanical work. And the dual autonomic system, coupled with the hormonal feedback from the duodenum, precisely regulates both secretion and speed.
And the clinical application.
Knowledge of the specific vascular territories and, critically, the lymph node stations, especially the distinction between N1 and N2, is what allows modern medicine to treat pathology like cancer with absolute curative precision.
And for you, the learner, here's a final provocative thought to chew on.
You now understand that your stomach's ability to safely store and then precisely grind and sort food is ultimately dependent on a network of tiny electrical pacemakers, the interstitial cells of Cajal, and a set of oblique muscle fibers acting like a noose. Next time you swallow, consider the immense complexity of controlling the pyloric sphincter. The ultimate gatekeeper that ensures liquids pass rapidly and solid food is pulverized via forceful retropulsion. All of this is regulated continuously by inhibitory feedback signals, the enterogastric reflex sent immediately from the duodenum, the system it is about to empty into.
The downstream system is controlling the upstream system.
This level of immediate downstream negative feedback regulation is truly astounding. So what other bodily systems rely on continuous negative feedback from their immediate downstream target to function correctly?